When it comes to containing costs in healthcare, everyone has their 2 cents to give. But what do those of us in the business of health insurance have to say? This is Health Sense, and I'm your host, attorney Adam Russo, CEO and co-founder of the FIA Group, a firm with over 25 years experience navigating this ever-changing industry. Join me and my guests as we make sense of effective ways to reduce the skyrocketing cost of healthcare while improving quality outcomes for patients. The only thing it will cost you is 30 minutes of your time. So let's get right to the bottom line and reimagine what healthcare could be. Hello, everybody, and welcome to Health Sense with attorney Adam V. Russo. That's me. And it's my inaugural show. This is the first show. I'm really excited. And many people have already asked, like, how did you end up being a host with your own radio show on Healthcare Now Radio? And I tell people, I just happen to be a guest. Tom Foley, who has a show on this station as well, invited me to be a guest. And I guess someone who had some importance or someone with some power was listening. I think it was one of the producers. And they said that in the 20 years they've been producing, I'm the second guest that they've ever heard who they thought should have their own show. So the first thing I did was I told my entire staff, and I go, we need a name for the show. And I could tell you, I got the worst names possible. I mean, I was offering money. I go to my family, nothing. And then the one person who I did not expect to give me any good feedback at all was my dad. And my dad, Franco Russo, who lives in Naples, Florida, says, how about Health Sense, but make it sense with a C, like money. He's like, you're all about saving money on healthcare. And you also want to try to make sense of what's going on in the market, what opportunities there are. And I'm like, I think it's pretty good. So here we are at Health Sense. What I'm hoping to bring is a couple things. One is I am a CEO of the FIA Group. We are a cost containment firm in the health insurance space. We primarily represent self-funded employers. And for those people in the audience that don't know, self-funding is roughly 2/3 of all of the employer-based healthcare in this country is based on a self-funding mechanism where the employer's money and their employees, the workers, their contributions to the health plan make up a pool of money that is then used to pay medical claims. So there is a risk factor. They take on the risk to do whatever they possibly can to offer the best possible benefits at the lowest possible prices. So I'm hoping that my perspective as a CEO, but in addition to that, my perspective as a father of 4 young kids, the oldest being 12, my twins being 9. Better say hi to Soli, Maeve, Sam, and Shay. Excited to do that. But in addition to that, I am also a coach. I coach everything: Little League, baseball, basketball, flag football, soccer, whatever it is. If I could coach them, if I could boss more people around than I already do, I tend to want to do it. So I'm hoping to bring all those perspectives into a show that I'm going to call Edutainment. I hope you're entertained, but I hope you learn something too. One of my favorite quotes of all time is by Albert Einstein, where he literally said, the definition of insanity is doing the same thing over and over again, hoping for a different result. And what I can tell you is that is literally what the health insurance industry is. It's what the entire healthcare environment is. Every year, copays go up. Every year, deductibles go up. Every year, premiums go up. Every year, the wait to see your doctor's longer. Every year, they just put more and more people on medication, just trying to over-medicate our population instead of trying to find the root causes of issues. So that's what I'm hoping to bring to the show. And the next big thing is after you come up with a name, who's going to be that first guest? And trust me, folks, I had a lot of different people I was thinking about. I reached out to 24 people, hoping that 5 would want to come on my show. And I can tell you that all 24 have asked to be guests. But the one person I wanted was like, okay, I need someone who's a pioneer. I need someone who's a disruptor. I also want someone who's got some brains. Okay, it didn't matter if they were good looking or not, because it's a radio show. So I'm like, the fact that this guy is not that attractive is not a big deal. But I also wanted someone who I respected and admired as a friend. And to me, it was pretty simple. The choice was Dr. Jeff Gold, who is with me here today. Dr. Gold is all those things. He's a doctor. He's a great dad. He's coached. And he's got some just really interesting, I would call, hobbies, let's say. And He loves to travel the country. He follows Pearl Jam. I know he's a big Pearl Jam fan. But first, I want to say welcome, Dr. Gold. Welcome, Jeff, as the first ever guest on Health Sense with Adam Russo. Welcome.
Wow. This is the biggest honor I think I've ever had in my life.
That's not saying much, Jeff, but
I know. But thank you very much for not only asking me to do it, but be your inaugural guest. I really appreciate it.
So just so everyone understands, I went on your website. I think it's golddirectcare.com.
Correct.
Read a little bit about yourself. You talked about how since you were in high school, you want to be a doctor, and you talked a lot about your grandmother as well. Again, just so everyone knows, he didn't get his degree online. He went to UPenn, undergraduate degree in biology, but then you also went to UMass Medical School and started your residency in 2005 in family medicine out in Scottsdale, Arizona, where 3 of my children were born. But what you're all about is direct primary care. So before we get going, tell us a little bit about yourself, your grandma, your residency, and then what direct primary care is, how you learned about it, and why you decided to get into it.
Yeah, I think to answer the first part, I grew up on the North Shore of Boston and went to high school in Swampscott and, ended up dealing with my grandmother getting very ill at a early age, 62. She started having symptoms and signs of dementia. And I think I questioned how the healthcare system worked from day one of residency, because what people don't realize is in medical school, we don't learn any of the business aspect of healthcare or medicine or insurance, like how that works.
You don't learn how to run or how to
Zero.
run a business.
Zero. There is no education on it at all.
You were a primary care physician for 10 to 12 years here in Massachusetts, right?
Correct.
All right. So what was the moment that you said, I can't do this? Now, before you answer that, I just want our audience to understand what the Association of American Medical Colleges, the AAMC, has said, that there will be a shortfall of close to 50,000 primary care physicians by the year 2036. In addition, what they say is that half of primary care physicians are over the age of 55 right now, approaching retirement. Fewer medical students are choosing primary care because primary reason is they don't get paid as much. I guess the average salary right now in primary care to be a physician is about $260,000 nationally, whereas a specialist can average $392,000 a year. That's a big difference. So with that in the background, what was your experience? And then what made you say, I love this job, I love taking care of people, but there's got to be a different way to do it, and direct primary care is what that is?
Yeah, I don't think I ever loved my job. Because I don't think it involved taking care of people the way that I thought, medicine would be, particularly in primary care. There's only so many people that you can see a day in 15, 20-minute increments, if you're lucky, and be able to assess, evaluate, and manage, multiple medical problems. If I'm a specialist and I'm a wrist surgeon and someone comes in and says, I've been depressed for 2 weeks, it's go see your primary. I'm here to deal with the wrist issue. But in primary care, if someone comes in depressed and says, also, I have wrist pain, that's on us to deal with. And unfortunately, when you're in the insurance-based model, which, to simplify it, I say for the first part of my career, I practiced insurance. I didn't practice medicine. Everything was billing, coding, documenting 3 pages of notes for someone who came in with a week of a cough.
So what I'm hearing, what I'm reading, what I've researched is that I'm assuming all the listeners on this call have a primary care physician if they have health insurance. I'm making that assumption. Is it really true that the average primary care physician sees between 25 to 30 patients a day? The average time of the appointments is somewhere between 10 and 15 minutes, and that you actually have, per doctor, over 2,000 patients assigned to you. Is that real?
Yeah, that's pretty close to accurate. And yeah, I had about 3,000 patients on my panel.
3,000?
Yeah. Now, the reality is there's maybe 1,000 that that you see pretty frequently. These are just people listing you with the insurance company. I mean, there are some people that I never saw because they would just ask for referrals. Yeah, but technically you're responsible for about average 2,000 to 3,000 patients. Some areas primary care docs will carry 4,000 depending on what the market and access are.
That's incredible. And the average time to see your doctor, to make an appointment, I'm being told is roughly 21 days. Was that your experience as well? Like if a person said, I need to see my doc, they're waiting 3 weeks?
Oh, not necessarily. I mean, because we would always have same day availability or next day availability, or there was, all the hospitals now own urgent care centers that basically see the overflow from the primary care offices with people that can't get in. But I would say waiting, to get them in with an appropriate referral to a specialist, yeah, it could take weeks to months sometimes. Basically, you're like a higher paid triage nurse. And for me, that it just got to the point where it didn't work. And
so what was that moment, Jeff?
The biggest one for me, and a lot of people don't know this, is that at the time, Medicare has their annual wellness visit now, which doesn't even include a physician looking at you, basically, when you look at the criteria. But prior to that coming into existence, Medicare does not pay for an annual preventative exam or an annual physical. But what do you do when that patient is 72, takes a baby aspirin a day and a multivitamin and has no chronic medical issues that you can diagnose?
Right.
And what happened is I had a little 80-year-old lady who I had to go in and see. And before I even, went in the room, I was more worried about how am I going to code this so she doesn't get hit with a $500 bill than actually going in, dealing with the issues and talking about prevention, whatever acute issue she wanted to deal with.
Just to actually talk to her about herself. What's going on?
I got really annoyed and I felt very angry towards her. And then that night, I thought to myself, am I really mad at her or am I mad at, because that could be my grandmother, that could have been my grandmother sitting there. And would I have been happy with the care that I delivered and how I felt internally if knowing that my grandmother's physician was feeling that way? And what I realized is I hated the system. I didn't hate the woman. I wasn't mad at her for being 82 and healthy and having like a few things she wanted to go over. I was mad at the system that basically gave me 10 to 15 minutes to not only talk to her about her concerns, which were all relative, but also then trying to figure out the scheme of how do I code and bill this where she's under the impression that this is a free Medicare physical. I just had enough at that point, and I never heard of direct primary care. I knew about concierge medicine. I just started scouring the internet. It was like, what is DPC?
So let's get into that. What year was this?
It was about 2013, 14, around there.
Okay. And at that time, direct primary care, you're going to talk to us a little bit about that. But there were no direct primary care offices or facilities in Massachusetts, correct?
Yes. At that time, based on my research, the only thing close that I could find was Iora Health that Dr. Fernanda Poulet from Mass General was running.
So what is DPC and how is it different than the primary care model that we just discussed?
So basically the way that I describe it, and being the self-insurance expert that you are, you'll understand this pretty clearly. And it's amazing to me that more of the public doesn't get this, but insurance is not meant to be a payment model. It's not meant to be a form of payment. Good insurance is supposed to protect you when the crap hits the fan and you don't want to go into financial ruin. But what's happened is, and I certainly have my theories of who created this belief system that everything in healthcare is so expensive that if you don't use insurance to pay for it, you'll go broke.
So instead of being a catastrophic care type coverage, right? Like it is for everything else, every other insurance you buy is tied to catastrophes. With our healthcare model, it's your office visit. You need insurance because it's too expensive. Everything that you would need needs to go through insurance.
Right. So what we do is we dumb the public down into thinking that everything is so expensive because there's no price transparency. No one knows what the hell anything costs, whether it's cost, quality, no one knows. The analogy I use is take a mammogram, for example. So when the ACA comes out, they sell everybody that we're going to cover all this, give you this free mammogram, right? So people think, oh God, thank God, my $3,000 mammogram now is free. But what we've done is we've cost shifted with higher premiums going up, higher deductibles, higher coinsurance, higher copays. So to me, if people actually knew that a mammogram, including the read, cost $250, my vote would be I'd pay if I were a woman, and I'd pay the average American would pay $250 a year for their mammogram. And God forbid, if there was a mass or something abnormal, their insurance would kick in and cover the treatment or the diagnostics, right? What we do is we say, we're going to give you this free mammogram because you think it's about $3,000. But then when you have an abnormality, you're now exposed to the average 3,000, 6,000 deductible before your insurance covers anything. So we have it all ass backwards in terms of insurance. So for me, what I realized is we are using the same payment model for me to take 10 minutes to look in a kid's ear to make sure it's not infected as we are for triple, quadruple bypass surgery. So
that's a great explanation, by the way.
It makes absolutely no sense. And for me, primary care should be accessible, insurable with an E, not an I, insurable, that everyone has access to good primary care. And we've actually made it expensive by insuring it. If you get the third parties out of primary care, you can get things at what they actually cost. You know, I'm not doing open heart surgery. I'm not doing brain surgery. You know, I'm not doing hip replacements. I'm not doing expensive things in the office, but we've made it expensive. And everything always ends up getting shifted onto the people somehow.
All right, so let's get to it. What is direct primary care? How does it work? You're the first doctor to actually do this in Massachusetts, open an actual practice. So what is DPC? Explain to the listeners how it's different than the model they're used to.
So true direct primary care at its core is a membership model. Think of it like Netflix. You pay a flat monthly fee to have access to me, whether it's telehealth, in-person, urgent care, chronic disease management. It's a flat monthly fee. We do age-based pricing because obviously older patients we think will take more time, more care coordination. But
what is the price range roughly?
For kids 21 and under, it's about $50 a month. And for 65 and up, I think we're like $140 now or something like that.
But then they have a copay too, right?
No, there's no fees. They have access. You know, if they have a quick question, they can email me directly. Nights and weekends, if there's anything urgent, they get my cell. They can text me, call me.
So you're telling me I could have, I'm a listener. I could have my own doctor. I'm 51 years old. So for roughly, looking at your website, 120 to 100, let's say $150 a month, $150 a month. I have a doctor 24/7 that I can access. If I don't feel good, if I need a flu shot, if I need a physical, if I just wake up feeling drowsy, I can pick up the phone, call you, text you, or I can come see you.
And the beauty of it is, you know, there's a lot of nuance in medicine, you know, and a lot of it is developing relationships with patients that we know you know us. You know, I know who the parents are, that if I get a call or an email on a Friday afternoon, that I'm not going to have any break over the weekend if I don't see that kid on Friday before the weekend, versus the parents I know who I can say, look, do this over the weekend. If the kid's worse or not better, reach out to me on Monday. Knowing personalities, and it's knowing patients. And so the way I phrase it is, think of it like a combination of Netflix and Costco. Netflix, we already covered. Costco, in the sense that by being a member of the practice, we actually get you testing at what it actually costs. And we just pass that savings on to you. So what we usually do is encourage people to, you know, carry a high deductible plan, which most plans are
People
now.
have anyways.
You know, and basically $600 of lab work at the hospital costs about $45 in our office.
Wow. So comparing the two, the average doctor in a primary care setting, like you said, 2,000 to 3,000 patients. How many patients do you have?
I have around 700, which allows me time and ability to manage those 700 patients.
You were telling us before you would see roughly 22 patients a day. You're working pretty quick. What's a typical day? How many patients do you see in a typical day in a direct primary care setting?
Typically, you know, I do our physicals, our annual checkups are an hour.
Okay. So you got an hour on the physical. What's your average amount of time that you're spending with your patients compared to the 10, 15, 20 minutes you were having?
We usually at least get 45 minutes.
So you're talking about 45 minutes to an hour. I'm assuming based on that, it's under 10 patients a day,
Yeah, I
roughly.
usually do one physical in the morning period, one in the afternoon, and then we leave the rest of the day open, for any sick visits, urgent care. I have one, physician assistant that works with me that'll help out. But the reality is, most people don't even need to be seen. Like most of it, can be done through health, a quick email, a quick phone call.
Text.
Right. When you're calling someone that knows you on the other end and knows your history versus somebody that knows nothing about you. So we try to make it as easy for people as possible. If you're a mom with 3 kids and you're running around and the kid pulls for 2 days, we can talk you through and give you some advice without having you have to bring the kid in and then wonder, what do I do with my other 2 kids?
As a kid, as a son of a mom who worked 3 jobs, taking the time off from work,
Mm-hmm.
her having to take a half day, her having to leave work early, her having to get me out of school early. As if my listeners can't tell by now, I have direct primary care. It is the number one greatest thing I've ever done for not only myself, but my entire family. To give you a little experience of what that experience is like. So, Jeff, I get sick today. I don't feel great. I just text you.
Mm-hmm.
You tell me, all right, let's have a quick phone call. We get on the phone. How you feeling? Let's talk it through. And then based on that, you'll say either come in today or
Mm-hmm.
tomorrow, or hey, try this, like you mentioned about the weekend thing. Try this, try that. If it doesn't work out, let's talk in a couple of days. If people do have to come in, what kinds of things can you do?
Yeah, I think there's a lot of people that unfortunately, never mind direct primary care, I don't think they have even seen what a highly trained primary care doc can do. But I mean, I do skin biopsies, I do wart removal, I do joint injections, simple laceration repair. Now, obviously, if someone comes in and they're bleeding out of an artery, like, they go to the ER. But,
Right.
a simple wound, I mean, I think the irony of the ivory tower arguments against this model, which the New England Journal just published one this weekend, and
Against it.
well, not against it, but explaining it and what some of the drawbacks are. And it's like the same tire drawbacks that were worsening the primary care shortage because we're taking fewer patients. No, the system's doing that. And then this is only for the rich and the wealthy. And no, actually, a majority of my patients, as you mentioned, are blue collar type people that, literally, if they miss 2 hours from work, there's 2 hours of pay they don't get. So if I can handle something through quick text and if they have it, I always say, if you have a cell phone, you can afford me. It's whether you want to or not. It's whether you see the value. Okay. That's the reality.
All right. So I have a question. We talked about DPC. And one of the things I mentioned at the beginning, the reason I wanted you on the air is because you're a pioneer. You were the first guy to do it. How many DPC practices do you think are there now, roughly? How many DPC doctors are there in the state of Massachusetts today, roughly?
I think it's about, since I opened in January 15, I think there's about 20 to 25. And I get an email or call at least a few times a month. I even got a call on Friday from a rheumatologist in Massachusetts that wants to do direct specialty care with rheumatology.
When you decided to go down this road, what was the reaction of the state from actually just opening up and hanging up your shingle, Dr. Gold, direct primary care? I'm going to charge you $100 a month if you want to see me. That's it. How long did it take you to get your office opened? How much do you have to spend roughly? And how much of a pushback was there? And who was that pushback from, if you wouldn't mind, in our last couple of minutes?
Yeah, I would say it took a good year of reading and research, and
Yep.
we did have to build out a space. It was probably about 300 in capital that it took to get equipment and all that. Now, if I just went the other way with a bank loan, I probably would have gotten a nice small office, used exam equipment, made it very nice, but just on a much lower cost margin.
So obviously you got the financing, you were able to get a great investor.
Yeah.
But how about from the state?
No, I
Any
mean,
pushback? What was the situation there?
oh yeah, before I even opened, one of our former neighbors was an editor at the Salem Evening News and wanted to do a story on me. So we did a story and took some pictures while the office was under construction. I was still working my old job at the time. And I think literally within 3 days, I got a call from the deputy commissioner of insurance in Massachusetts asking me,
Insurance,
yes,
not
asking me,
not a doctor's board or clinical board. Insurance.
yes, saying that they wanted to know what DPC was and is because it may fall under their purview of regulation, i.e., you're paying me a monthly fee. I'm being the insurance company and would have to pay regulatory fees, no different than Blue Cross, Harvard Pilgrim, whatever. So my lawyer at the time, who was a healthcare attorney, go to the insurance commission and then explain why DPC is not insurance. The only financial transfer of risk is if people don't sign up with me.
And I think we're one of only 2 states that you cannot dispense medication, correct?
Yeah, it's about 5 states that doctors are not allowed to dispense more than a 3-day emergency supply of medication. So a lot of my colleagues in other states dispense wholesale meds. So some of their Medicare patients, they're saving huge amount of dough on meds.
Give me one example of a patient. Patient comes in and you go, yep, you got to have this script, what you could be doing if Massachusetts allowed it versus what they have to do because we don't allow it.
You take like a typical Z-Pack for pneumonia. We could dispense it from the office at $1.30 for the 6 tablets.
Okay.
But instead, we have to send it to the pharmacy. They automatically run it through insurance. Half the time, the copay is more than what the actual drug costs.
So the copay can be $25, $30 for something that costs $1.30.
Yeah. And unfortunately, a lot of the chain pharmacies are not going to tell the patient that it's just cheaper if they pay cash.
Cash. So Jeff, we're out of time. How do people get in touch with you?
Best way is really just email me. My email's always cooking. It's Dr. Gold, DRGOLD at golddirectcare.com.
You're located where?
63 Jefferson Ave in Salem, Mass.
Well, Jeff, listen, I thank you so much for the time. Being with us today as our first ever guest. Maybe I'll send you some kind of gift and it'll be a tie to Cleveland because everyone needs to know on this radio show how much I love the city of Cleveland and all those Cleveland.
Just give me Pearl Jam tickets the next time they play Cleveland.
Pearl Jam tickets in Cleveland is what you want as your gift. I think I could come through with that. Thanks so much, Jeff. Folks, this has been Health Sense with Adam Russo. Tune in 10 a.m., 6 p.m., and 2 a.m. on Healthcare Now Radio. It's been a pleasure to be with all of you, and I hope that you learned something today that you didn't know. Direct primary care, the way to go. Have a great day.